Welcome to the deep dive. When you think about it, something like putting in eye drops or ear drops seems simple, right?
Hmm.
But actually, there's a whole lot of crucial knowledge behind it. Getting it right means safety and effectiveness.
Absolutely. It's deceptively complex sometimes, and that's exactly what we're digging into today.
Right. We're doing a really thorough exploration of the chapter on eye and ear medications. We're using the Saunders Comprehensive Review for the NCLEX-PN Examination, 7th edition, as our guide.
Yeah, think of this as your guided tour. We'll hit all the critical stuff you really need to grasp.
So whether you're maybe prepping for practice or perhaps trying to understand treatments for yourself or someone else, or, maybe you're just curious of this for you.
Our mission today is pretty clear. Pull out the most vital nursing concepts, the administration guidelines, safety rules, potential problems, and just the key takeaways for both ophthalmic, that's eye and anodic, or ear medications.
Okay, let's jump right in. Eyes first.
Sounds good. When we're talking about eye medications, precision is absolutely key. They mostly come as either drops or ointments.
And each has its own way of being put in, I imagine.
Exactly. And it's not just about getting the medicine in the eye.
Ah, right. You also need to make sure it, stays put and doesn't cause problems elsewhere.
Precisely. We want to minimize the chance of it draining down the little tear duct into the nose
Yeah.
and getting absorbed systemically. That could cause side effects you don't want.
So how do you stop that?
It's actually quite simple. Just gentle pressure over the inner canthus, that corner of the eye near the nose, for about 30 to 60 seconds right after the drop goes in.
Okay, like closing off a tiny drain temporarily.
You got it.
Yeah.
And gently closing the eye helps spread the medication too. No squeezing though, just a gentle close.
Makes sense. Keep it local. Now, what if someone needs both drops and ointment? Is there an order?
Good question. Yes, definitely. Drops always go in first.
What's that?
Well, you want the drops to make full contact with the eye surface before you put in the ointment, which is thicker and can kind of form a barrier.
Gotcha. Drops first, then ointment. And of course, cleanliness. Super important in healthcare. How does that apply here?
Oh, it's absolutely fundamental. Always, always wash your hands thoroughly first. Then put on gloves.
Prevents contamination.
Right. Protects the eye, protects the medication bottle. And another critical point, each patient gets their own bottle or tube. No sharing. Ever. Prevents cross-contamination.
Okay, own bottle. And where exactly does the drop or ointment go? Not just anywhere on the eyeball, right?
Definitely not. You aim for the lower conjunctival sac.
The little pouch.
Yes, that little pocket you see when you gently pull the lower eyelid down. It's the perfect spot. Never apply it directly onto the cornea, the clear front part.
Why not the cornea?
It's incredibly sensitive. Lots of nerve endings. Direct application can cause discomfort, maybe even minor damage. Plus, and this is crucial too, avoid touching the dropper tip or the ointment tube tip to any part of the eye. Eyelid, lashes, eyeball, no contact.
Keeps the medicine clean.
Exactly.
What if someone's on, say, multiple different eye meds? We covered drops before ointments. Any other order rules?
Yes. If a glucocorticoid eye prep is prescribed, a steroid that generally goes in before other types of eye meds.
Ah, okay. Why is that?
The thinking is to let the anti-inflammatory effect of the steroid work first before you add other things.
Yeah.
Maximize its impact.
Interesting. I also remember something about checking the pulse with certain eye drops.
You're right. Specifically with ophthalmic beta blockers, sometimes used for glaucoma,
Why check the pulse?
because they can be absorbed systemically and affect the heart rate. So you monitor the patient's pulse, and importantly, you teach the patient how to check their own pulse.
Self-monitoring.
Yes, and the prescriber will set parameters like hold the dose if your pulse is below 60, for example. Then they contact their provider.
So patient education sounds like a really big piece of this puzzle.
Oh, absolutely. You have to explain how to do it correctly, then watch them do it. Supervise until you're sure they've got it down safely.
What about people who have trouble, like shaky hands?
Good point. There are adaptive devices available that can help hold the bottle steady. And always, always stress reading the label. Every single time. Check the drug name, check the strength.
Standard medication safety and storage. Keep away from kids.
Without a doubt. Store them securely where children can't reach them. And another big one, if vision gets blurry after using the drops or ointment.
No driving.
Right. No driving, no operating potentially dangerous machinery until their vision is clear again.
Makes total sense, especially thinking about drops used for eye exams, the ones that dilate your pupils.
Exactly. Mydriatics dilate the pupils, cycloplegics paralyze the focusing muscles. After those, vision will be blurry for a while. Driving is definitely out.
And those dilated pupils probably make you sensitive to light, too.
Yes, photophobia. That's
Yeah.
common. So advise wearing sunglasses, avoiding really bright light until it wears off.
What if someone just forgets a dose? What's the usual advice?
Generally, take the missed dose as soon as you remember. Unless
Unless...
it's almost time for the next, sometimes, yes. Especially initially, they might feel some stinging, maybe some burning or temporary blurred vision. It's important they know this might happen, but also that they should report any new or worsening eye irritation right away.
Okay. And storage for these. Any special rules? Like for eye gels?
Eye gels, yeah.
Yeah.
Usually room temp a fridge is okay, but never freeze them. And if you store it at room temp after opening, there's often a specific discard date, maybe 4 weeks, something like that. Check the packaging or ask the pharmacist.
What about contact lens wearers? Do they need special instructions?
Oh, definitely. Soft contacts can actually absorb some eye meds, and preservatives in some drops can discolor soft lenses. So they absolutely need to talk to their provider. They might need to take lenses out before putting drops in and wait maybe 15 minutes or so before putting them back in. Depends on the drop.
Got it. Are there any really specific instructions for infants getting eye drops?
Yes, one example is atropine sulfate drops. These have anticholinergic effects systemically, meaning they can slow things down, like bowel movements. So for an infant on atropine drops, parents need to track bowel movements, and the nurse should listen for bowel sounds.
Wow, okay. Didn't realize eye drops could do that. One last timing question. If you need multiple different eye meds close together, how long between them?
Good rule of thumb is wait at least 3 to 5 minutes between different types of eye drops.
Why the wait?
Gives the first drop time to get absorbed properly, prevents the second drop from just washing the first one out immediately.
Okay, 3 to 5 minutes between different drops. Got it. Those are great general guidelines. Now let's walk through the actual process, putting in drops first.
Right. Step 1, wash your hands, put on gloves. Step 2, check the medication order carefully. Right drug, right strength, not expired.
Okay, then.
Have the patient tilt their head back a bit, look up at the ceiling, gently pull the lower eyelid down to make that little pocket, the conjunctival sac.
And how do you hold the bottle?
Hold it like a pencil, tip down. And here's a tip for stability. Rest your wrist gently on the patient's cheekbone.
Ugh, good idea. Prevents shaking.
Exactly. Then gently squeeze one drop into that sac. Remind the patient, close your eye gently, don't squeeze it shut.
What if the order is for, say, 2 drops?
If it's 2 drops of the same medicine, you still wait that 3 to 5 minutes between drop 1 and drop 2.
Okay, and remind me about not touching the eye.
Absolutely critical reminder. Don't let the bottle tip or the dropper or the ointment tube touch the eyelid, eyelashes, or the eye surface. Contamination risk. And finally, remember that punctual occlusion.
Pressure on the inner corner.
Yes, with a clean tissue, gentle pressure right there for 30 to 60 seconds. Minimizes systemic absorption.
Got it. Drops covered. Now, eye ointments, how's that different?
For ointment, have the patient lie down or tilt their head back and look up. Hold the tube close, but again, don't touch the eye with a tip.
Then what?
Squeeze a thin ribbon, just a thin line of ointment into that lower conjunctival sac. Go from the inner corner outward.
A thin ribbon, inner to outer. Then?
Patient closes their eye gently, then rolls their eyeball around. Up, down, side to side.
Spreads the ointment.
Exactly. And definitely let them know their vision might be blurry for a bit because the ointment is greasy. That's why applying it at bedtime is often best.
Right. Less inconvenient if you're going to sleep. Okay, let's dig into some specific types of eye meds now. First up, Mydriatics, cycloplegic, and anticholinergic medications. Big words. What do they do?
Okay, let's break it down. Mydriatics dilate the pupil, that's mydriasis. Cycloplegics paralyze the ciliary muscle, the focusing muscle that's cycloplegia.
And anticholinergics.
Anticholinergics are often the drugs that cause these effects by blocking acetylcholine, a neurotransmitter, in those eye muscles.
So why use them? When would you need dilated pupils and paralyzed focusing?
Primarily before eye surgery, so the surgeon can see inside better. Or during a really thorough eye exam, again, to get a good look at the retina and optic nerve.
Makes sense. Are there people who shouldn't use these? Contraindications.
Yes, big one. Narrow-angle glaucoma. Dilating the pupil can actually block fluid drainage in those patients and dangerously increase eye pressure, so generally contraindicated.
Okay, no Mydriatics in narrow-angle glaucoma. Any others?
Use with caution in people with heart rhythm problems, cerebral atherosclerosis, hardening of arteries in the brain. Also, be cautious with older adults and folks with prostatic hypertrophy, diabetes, or Parkinson's. The anticholinergic effects can worsen some of those conditions.
What about side effects people might feel?
Could include a faster heart rate, tachycardia,
Yeah.
sensitivity to light, photophobia, maybe some conjunctivitis, a skin rash, even a temporary rise in blood pressure.
The chapter mentions atropine toxicity. What does that look like?
That's a more serious systemic reaction. Signs could be dry mouth, blurred vision, photophobia again, fast heart rate, fever, trouble urinating, constipation, headache, confusion, even hallucinations or delirium. And it can definitely worsen glaucoma.
Any other general systemic reactions from these anticholinergic eye drops?
Yeah, if enough gets absorbed, you might see dry mouth and skin, fever, thirst, confusion, maybe hyperactivity.
So nursing interventions. What are the key things to watch for and do?
Monitor for any allergic response, definitely. Assess their fall risk. Blurred vision or confusion can increase it. Check for constipation or urinary retention.
Okay. What do you tell the patient?
Tell them it might burn a little when the drops go in. Advise no driving or hazardous activities for maybe 24 hours, unless the doctor says otherwise. Wear sunglasses for light sensitivity.
And when should they call the doctor?
Report persistent blurred vision, any vision loss, trouble breathing, sweating or flushing, or any eye pain right away. And always, always remember that glaucoma, contraindication. Big safety point.
Got it. Okay, moving on. Anti-infective eye medications. For infections, obviously.
Right. These kill or stop the growth of bacteria, fungi, viruses causing eye infections.
Downsides, side effects.
Two main things to watch for. One is superinfection. That's when treating one bug allows a different bug to overgrow. The other is just general eye irritation, redness, itching, discomfort.
What are the key nursing points for these?
Again, assess fall risk if vision's affected. Really reinforce the right technique and emphasize cleaning any gunk or discharge away before putting the drops or ointment in.
And finishing the whole course.
Absolutely crucial. Finish the entire prescription, even if it feels better sooner. Stress good hand washing to prevent spreading it. And tell them to call the provider if things aren't improving.
Next, anti-inflammatory eye meds.
These are used to control inflammation. Think conditions like uveitis, allergic reactions, conjunctivitis, keratitis, blepharitis. They reduce redness, swelling, pain. It can help prevent long-term issues like scarring or vision loss.
Any particular side effects to be aware of here, especially with steroids?
Yes, long-term use can potentially lead to cataracts, increased eye pressure, and slower healing, especially if there's a corneal injury. Also, because they suppress inflammation, they can sometimes mask an underlying infection.
Make it harder to spot an infection.
Exactly. So you need to be vigilant.
Nursing interventions similar to the anti-infectives.
Pretty much the same general principles apply: proper technique, monitoring, hand hygiene. But one really important note: dexamethasone, a common steroid drop, is generally a no-go if there's a corneal abrasion or wound. It can really impair healing.
Good point. Okay, how about topical eye anesthetics? Numbing drops.
Right. They numb the cornea and conjunctiva. Used mostly for exams, minor procedures like removing a foreign body, or some types of surgery. Makes it comfortable for the patient.
Any special handling?
Yeah, don't use the solution if it looks discolored. Keep the bottle tightly closed. Tetracaine is a common one you might see.
Side effects? Just stinging?
Usually temporary stinging or burning when it goes in. And importantly, they temporarily knock out the corneal reflex.
The blink reflex. Why is losing that a big deal?
It's the eye's natural protection. Without it, the eye is vulnerable. That's why these are strictly for clinic or procedure use, never for the patient to take home and use themselves.
Okay, so what do you do after using them in the clinic?
Tell the patient not to rub or touch that eye. Because the blink reflex is gone, you often put an eye patch on to protect the cornea until the numbness wears off and the reflex returns.
Makes sense. Protect the eye while it can't protect itself. How about eye lubricants? Artificial tears.
Pretty straightforward. They replace or supplement natural tears, add moisture. Used for dry eye, moistening contacts or artificial eyes, protecting the eye during surgery, or for conditions like keratitis or when blinking is reduced, like in unconscious patients.
Any downsides?
Sometimes people feel a bit of burning or discomfort right when they put them in, and allergic reactions to the preservatives in some formulas are possible.
What do you tell patients using these?
Let them know about the potential brief burning and watch for any signs of allergy, more redness, itching, eyelid swelling. could be the preservative.
Okay, now let's really focus on glaucoma meds again. Several categories here. What's the main goal?
The main goal for almost all glaucoma meds is to lower the intraocular pressure, the IOP.
How do they do that?
Different ways. Some, called Mydriatics, make the pupil smaller and contract the ciliary muscle. This helps fluid the aqueous humor drain out better.
Meiosis pupil constriction.
Right. Others work by directly opening up the drainage angle in the front of the eye, also helping fluid outflow.
Are there times when these miotics shouldn't be used?
Yeah. Contraindicated if someone has a retinal detachment or adhesions between the iris and the lens or active eye inflammation. And use cautiously in folks with asthma, high blood pressure, corneal abrasion, thyroid issues, heart disease, urinary or GI obstructions, ulcers, Parkinson's, or a slow heart rate.
Wow, that's a lot. Why so many cautions?
It relates to potential systemic side effects. Mydriatics are cholinergic drugs. They can affect breathing in asthma patients, impact heart rate and blood pressure, increase GI and urinary activity.
What are common side effects just in the eye?
Things like temporary nearsightedness, maybe a headache or brow ache, eye pain, definitely trouble seeing in dim light or at night because the pupil is small, and local irritation.
And more serious adverse effects, systemic ones.
You could see skin flushing, sweating, nausea, vomiting, diarrhea, frequent urination, more saliva, muscle weakness, even trouble breathing.
And toxicity, if too much gets absorbed.
Signs could be dizziness, fainting, really slow heart rate or other rhythm problems, low blood pressure, tremors, even seizures.
So given all that, what are the key nursing interventions for miotics?
Monitor vital signs, heart rate, blood pressure, very important. Assess fall risk from dizziness or vision changes. Watch for all those side adverse toxic effects. Check for postural hypotension. Tell them to change positions slowly. Listen to breath sounds for wheezing.
What else?
Good oral hygiene because of the extra saliva. Make sure atropine sulfate is available. It's the antidote for pilocarpine toxicity. Teach administration carefully. Stress, not stopping abruptly. Advise against driving if vision's poor. And tell them to check OTC med labels. Avoid anything with atropine-like effects.
Okay, that covers miotics well. Let's switch to beta-adrenergic blockers for glaucoma. How do they work?
Beta blockers also lower IOP, but mainly by reducing how much aqueous humor the eye produces. They block beta receptors in the ciliary body. A key difference from miotics is they usually don't affect pupil size or focusing ability.
Contraindications. Precautions.
The big ones are asthma and COPD. Systemic absorption can tighten airways. Also, use caution if the patient is already taking an oral beta blocker. The effects can add up.
Side effects for beta blocker eye drops.
Can cause eye irritation, stinging, dry eyes, visual disturbances. Systemically, you worry about slow heart rate, bradycardia, low blood pressure, hypotension, and that bronchospasm risk.
Nursing interventions. Sounds like vital signs are key again.
Absolutely. Check blood pressure and pulse before giving the drops. Have specific parameters from the provider, like hold if pulse is below 60 or systolic BP below 90, and notify them. Tell patients to report any shortness of breath immediately.
And like miotics, don't stop abruptly.
Correct. Don't stop suddenly. Change position slowly for orthostatic hypotension. Avoid hazardous activities if vision's off. No OTC meds without checking with the provider first. And for diabetics, beta blockers can mask signs of low blood sugar, so they need to monitor glucose closely.
Got it. Next category. Carbonic anhydrase inhibitors. Another way to lower IOP.
Yes, these interfere with an enzyme, carbonic anhydrase, needed to make aqueous humor. So, less fluid production, lower pressure. Often used for long-term glaucoma management, can be drops or pills.
Any big contraindications here? Allergies?
Yes, definitely contraindicated if someone has the sulfonamide allergy, a sulfa allergy, because these drugs are chemically related. Use with caution in severe kidney or liver disease.
What about side effects? These sound like they could be more systemic, especially if taken as pills.
They can be. Things like loss of appetite, GI upset, tingling in fingers, toes, face, that's paresthesia, increased urination, low potassium levels, risk of kidney stones, sensitivity to sunlight, feeling tired or drowsy, even depression.
So nursing care involves watching for a lot of different things.
It does. Monitor vitals, vision, assess fall risk due to drowsiness, track intake output, weight, monitor electrolytes, especially potassium if they're on the oral form. Encourage fluids to help prevent kidney stones unless fluids are restricted for another reason. Advise sun protection.
What else?
Good oral hygiene. Use artificial tears if eyes get dry. Again, don't stop abruptly. Avoid hazardous activities if drowsy or vision impaired. And if using the drops, avoid contacts during and for about 15 minutes after putting them in.
Okay, let's talk about the OcuCert system. Sounds different.
It is. It's a tiny medicated disc or wafer containing pilocarpine. The patient puts it in the conjunctival sac under the upper or lower limb.
It stays there.
Yes, it releases the pilocarpine slowly over a whole week. Then they take it out and put a new one in. The idea is more consistent medication delivery, fewer drops needed.
Sounds handy. Any downsides?
Yeah, potential issues include sudden leaking of the drug, the disc moving around and irritating the cornea, or it falling out without the patient noticing.
So what do nurses need to teach patients about OcuCert?
First, make sure they can actually insert and remove it properly. The discs need to be stored in the fridge. Discard any damaged ones.
Yeah.
Tell them it might sting a bit at first, but report ongoing blurred vision or brow pain.
And checking it's still there?
Yes. Check daily bedtime and morning to make sure it hasn't fallen out. Best time to insert a new one is usually at bedtime, as vision might be a bit blurry initially.
Interesting delivery system. Now, osmotic medications like mannitol, when are these used?
These are powerful diuretics used to lower IOP really quickly. Think emergency treatment for acute angle closure glaucoma, or sometimes before or after eye surgery to reduce the volume inside the eye.
Side effects, since they're potent diuretics.
Exactly. Can cause headache, nausea, vomiting, diarrhea, definitely dehydration risk, also disorientation and electrolyte imbalances.
Nursing focus.
Close monitoring. Vitals, vision. Fall risk assessment due to potential disorientation. Strict intake output, daily weights. Watch electrolytes closely. Encourage fluids if allowed. Monitor mental status.
Okay, last category for eyes. Medications for macular degeneration. A big issue for older folks.
Huge issue. Age-related macular degeneration, ARMD. Two main types. Dry ARMD is more common, slow breakdown of cells, gradual blurring of central vision. Wet ARMD is less common, but worse. Abnormal blood vessels grow, leak fluid and blood, cause faster, more severe central vision loss. Both involve drusen those yellow spots under the retina.
And there are treatments now, especially for the wet form.
Yes, several drugs like pegapinab, ranizumab, bevacizumab, aflibercept, they target the abnormal blood vessel growth, usually given as injections directly into the eye, intravitreal injections.
Injections into the eye, wow. Side effects.
Potential risks include a serious infection inside the eye called endophthalmitis. Also blurred vision, cataracts, corneal swelling, eye discomfort or discharge, bleeding on the eye surface, increased eye pressure, even reduced vision sometimes.
What's the nurse's main role here?
Mostly reinforcing teaching, making sure the patient understands the procedure, the potential side effects, and critically, who and when to call if they have problems, like sudden vision changes, pain, redness, more floaters. Prompt reporting is key.
Okay, we have thoroughly covered eye meds. Let's shift gears now to the ears otic medications. How do you put in eardrops? Is it different for kids?
Yes, the technique changes slightly with age to straighten out the ear canal properly. For adults and kids over 3, you gently pull the outer ear, the pinna, up and back.
Up and back for adults and older kids.
Right. But for infants and children under 3, you pull the pinna down and back.
Down and back for little ones, then what?
Tilt the head so the affected ear is pointing up. Put the prescribed number of drops in. Keep the head tilted for a few minutes. Gently moving the ear or pressing the tragus, that little flap in front, can help the drops go down.
Okay. What about irrigation, washing out the ear?
That needs a doctor's order. Usually done for impacted earwax or maybe a foreign object. You need to be able to see the eardrum first, make sure it's intact.
And the water temperature.
Crucial. Warm the solution to body temp about 98 degrees F, 37 C.
Yeah.
Too cold or too hot can cause dizziness, nausea, even injury.
How do you actually do the irrigation?
Gently. Aim the stream towards the side wall of the ear canal, not directly at the eardrum. Let the fluid swirl behind the wax to flush it out. Patient's head tilted up, basin underneath to catch the drainage. And watch out for dizziness, fall precautions.
When would you not irrigate?
Absolutely contraindicated if you know or even suspect the eardrum is perforated.
Good safety point. Now, the chapter mentions systemic meds that can affect hearing. Ototoxicity.
Yes, really important. Some drugs taken by mouth or injection can damage the inner ear. Hearing loss, tinnitus, ringing, or buzzing, balance problems.
What kinds of drugs?
Certain antibiotics are notorious, especially aminoglycosides like gentamicin, some diuretics like furosemide, even high doses of aspirin or NSAIDs, and certain chemotherapy drugs like cisplatin.
So always ask about medications if someone reports hearing changes.
Definitely. A thorough med history is essential.
Let's talk about anti-infective ear medications now. For ear infections.
Right. Usually drops for outer ear infections, otitis externa. Sometimes for middle ear infections, if the eardrum is perforated and draining.
Contraindications.
Side effects. Main contraindication is a known allergy to the drug. A possible side effect is, like with eye drops, overgrowth of other organisms, a secondary infection.
Nursing points for these.
Check for allergies first. Monitor vital signs. Assess their ear pain. Watch for signs of any secondary infection. Tell them to report dizziness, fatigue, fever, sore throat. Finish the whole course. And keep the ear canal dry during treatment.
What about antihistamines and decongestants for ear issues? How do they help?
They're sometimes used for middle ear infections, otitis media. Decongestants shrink swollen nasal passages and the eustachian tube lining.
The tube connecting the ear and throat.
Exactly. Opening that tube can help drain fluid from the middle ear. Antihistamines might help if allergies are involved, usually taken orally.
Side effects, drowsiness.
Yeah, drowsiness, maybe blurred vision, dry mouth are common. So advise fluids, hard candy for dry mouth. Avoid driving if drowsy. And a caution. People with high blood pressure should check with their provider before using decongestants as they can raise BP.
Okay. Last category for ears, cerumenolytics, wax softeners.
Exactly. Eardrops like carbamide peroxide that help emulsify and loosen impacted earwax makes it easier to remove.
Side effects, irritation.
Can cause mild irritation, redness, or swelling sometimes. Tell patients not to use them more often than prescribed. Maybe use a cotton plug moistened with the drops after putting them in. Keep the bottle closed tight, away from moisture. Don't touch the ear with a dropper.
Do you need to irrigate after using them?
Often, yes. Gentle warm water irrigation with a bulb syringe about 30 minutes after using the drops can help flush out the softened wax. Sometimes mineral oil is used regularly for chronic impaction. Tell them to call the provider if redness, pain, or swelling gets worse or doesn't go away.
Okay, great rundown of the meds. Now, remember that critical thinking scenario, the client with shaky hands needing eye drops. What was the takeaway?
It really emphasized assessment and problem solving. If self-administration is tough due to shaky hands, the nurse needs to act. Maybe arrange a home care assessment. Or, with consent, teach a family member or caregiver. And definitely suggest looking into those adaptive devices we mentioned earlier. Find a solution that ensures the patient gets their medication safely.
Good practical advice. The chapter ended with practice questions. Let's hit a few key rationales quickly. Why monitor blood pressure with Betaxol eye drops?
Betaxol is a beta blocker. Even as an eye drop, it can be absorbed systemically and lower blood pressure. So monitoring BP is crucial.
Proper technique for ear irrigation. What was key about the solution?
Warming it to body temperature, around 98 F or 37 C, avoids dizziness and discomfort.
Cyclopentolate before cataract surgery. What's its main job?
It dilates the pupil, mydriasis,
Yeah.
and paralyzes focusing, cycloplegia. Before surgery, the main goal is pupil dilation for better surgical access.
How do you minimize systemic effects of eye drops right after putting them in?
Punctual occlusion. Gentle pressure on the inner corner of the eye, the nasolacrimal duct, for 30-60 seconds.
Order for drops and ointment in the same eye.
Drops first, then ointment.
Which drug is contraindicated in glaucoma? Atropine sulfate.
Yes. Atropine dilates the pupil, which can block fluid drainage and dangerously increase pressure in narrow-angle glaucoma.
Key steps for administering eye drops generally.
Hand hygiene, gloves, head back, look up, pull lower lid down, and still drop into conjunctival sac, no touching. Close eye gently. Punctual occlusion if needed.
Roaring sounds in the ears after starting a new med, likely culprit.
Aspirin, acetylsalicylic acid. Ototoxicity, often presenting as tinnitus, ringing or roaring, is a known side effect, especially at higher doses.
Antidote for pilocarpine toxicity.
Atropine sulfate. Have it available if administering pilocarpine.
And the main action of myotics for glaucoma.
They constrict the pupil, miosis, and contract the ciliary muscle, which improves the outflow of aqueous humor, lowering eye pressure.
Finally, how does all this eye and ears stuff connect back to the bigger picture of neurological nursing?
Well, sensory perception, vision, and hearing is deeply tied to neurological function. Many neurological conditions affect these senses, so understanding these meds, assessments, and safety measures is vital for comprehensive neurocare. It ties into preventing falls, collecting accurate data, teaching patients, addressing psychosocial impacts of sensory loss, and safe medication management.
We have certainly covered a tremendous amount of ground today, a true deep dive into eye and ear medications based on that Saunders chapter.
Absolutely. We've hit the key nursing concepts, the how-tos of administration, crucial safety points, potential side effects, contraindications. It really highlights that even seemingly simple treatments require significant understanding for safe and effective care. We've completed a thorough review of this entire section.
It definitely underscores how vital these senses are. Here's something to think about. Consider the medications you or people you know use. Maybe look into how they work, and if they might have any broader effects on the senses beyond just the eye or ear. It's all interconnected.
Great point.
Thank you so much for joining us on this very comprehensive deep dive.